Good evening everyone. Today we'll study about sickle cell anemia. Before studying about sickle cell anemia, we'll study about various types of hemoglobins. Hemoglobin A, that is found in adult in about 95 to 98% individuals, which is having subunit alpha 2 beta 2. Then hemoglobin F, that is fetal hemoglobin, which is found in 1% of individuals, which has the subunit alpha 2 gamma 2. Then we have hemoglobin A2, that is found in 3.5% of individual having subunit alpha 2 delta 2. Then what are hemoglobinopathies? These are the disorders of the hemoglobin. It can be qualitative and it can be quantitative. In qualitative, there is structural abnormality in the synthesis of hemoglobin, as in case of sickle cell anemia. In quantitative, there is decreased globin chain synthesis of hemoglobin, as in case of thalassemias. Now, what is sickle cell anemia? It is an autosomal recessive disorder due to the presence of sickle hemoglobin, that is HbS, in red blood cells. Red cells with hemoglobin S develop sickling when they are exposed to low oxygen tension. Now, what is sickle cell syndrome or sickle cell disorder? It can be heterozygous having hemoglobin A and S. It can be homozygous having hemoglobin H, S and S. It can be double heterozygous. Heterozygous AS is found in sickle cell trait. Homozygous SS is found in sickle cell anemia, and double heterozygous is found in sickle C disease. Sickle cell anemia is an homozygous state of HbS in red cells. There is an abnormal gene that is inherited from each parent. Now comes the pathogenesis of sickle cell anemia. First of all, there is hemoglobin, which is having two units, alpha unit and beta unit. In beta globin chain, there is mutation at chromosome number 11. In this, there is single point mutation at 6th position of beta globin chain, in which there is substitution of glutamic acid by valine, which leads to sickle cell anemia, that is hemoglobin S. Now here we'll study about the consequences of sickling. First, there is vasoocclusion of microcirculation. When there is deoxygenation of hemoglobin S containing RBC, it leads to polymerization of deoxygenated hemoglobin S. That leads to the formation of elongated rod-like polymers. And it leads to distort the RBC into sickle shape that express the higher level of adhesion molecule. And finally, there is vasoocclusion of microcirculation. Second consequence of sickling, we have hemolytic anemia. With repeated deoxygenation and sickling, there occurs membrane damage permanently, which leads to RBC becomes sickling, and there is difficulty in passing through splenic sinusoids. There is rapid phagocytosis, and that leads to extravascular hemolysis. Third consequence of sickling is increased MCHC, mean corpuscular hemoglobin concentration. When there is membrane damage, water comes out of the cell. That leads to intracellular dehydrogenation, and which leads to increased MCHC. Now, what are the factors that determine the rate of sickling? It is amount of hemoglobin S and its interaction with other hemoglobin. In homozygous individuals, we have 100% hemoglobin S. In heterozygous, we have 60% of hemoglobin A and 40% of hemoglobin S. In this case, hemoglobin A has inhibitory effect on hemoglobin S. Now, in another heterozygous, when there is 60% of hemoglobin F and 40% of hemoglobin S, as in case of infants, then hemoglobin F has inhibitory effect on hemoglobin S. In this, newborn will not have symptoms until he turns 6 months. Now, second factor is hemoglobin concentration of RBC, that is MCHC. Greater the MCHC, greater the sickling. Then comes intracellular dehydration, which is inversely proportional to sickling. Greater the intracellular dehydration, lesser the sickling is there. Now, decrease in pH. It reduces the oxygen affinity for hemoglobin that facilitates the sickling. Another factor is length of time for which red cells are exposed to low oxygen tension. Now the clinical features of sickle cell anemia. One is anemia, second we have vaso-occlusive phenomenon that takes place in bone, hand or foot. In this case, our cheekbone become prominent. In case of lungs, there occur acute chest syndrome. In brain, there occur stroke. In skin, there occur ulcers. In spleen, in the initial stages, it undergoes splenomegaly, but due to prolonged hypoxia and infection, it can lead to autosplenectomy. Then comes screening. For screening, we'll do sickling test. We'll take the sample of blood and we'll add sodium metabisulfite, which is a reducing agent, to it. And under the microscope, we'll see if we'll see normal RBC, then it will give negative test. And if we'll see sickled RBC under the microscope, it will give positive test, that is HbS, that is sickle cell anemia. Now comes the diagnosis. First we'll do microscopy, under which we'll see sickle cells, target cells and Howell-Jolly bodies. Second we'll do ESR, that is erythrocyte sedimentation rate, which will be decreased in case of sickle cell anemia. Then third test we'll do electrophoresis. In this you will see the normal. This blue band is showing hemoglobin A. Then sickle cell trait will show both the hemoglobin. 60% will be hemoglobin A and 40% will be hemoglobin S. Then in sickle cell anemia, 100% will be hemoglobin S. So these bands can be detected as, in case of normal, hemoglobin A will move faster towards the anode, and hemoglobin S, that is in case of sickle cell anemia, this band will move slower towards the anode. Thank you.